Caregiver series. In this video, we're tackling the crucial topic of oral care. We are honored today to be joined by Dr. Joel Epstein. Dr. Epstein is a highly accomplished and respected specialist in the fields of oral medicine and oral oncology. He's the Director of Oral Health Services in the Division of Head and Neck Surgery and a Professor of Oral Medicine at City of Hope. He's also a Professor and Medical Director of Oncology Dentistry at the Comprehensive Cancer Institute at Cedars-Sinai Health System in California. Dr. Epstein has a special interest in the oral health of cancer patients. He is dedicated to the early detection and management of oral changes, providing pre-treatment oral care before cancer therapy, and managing the oral complications of cancer treatment. Dr. Epstein has published in the area of oncology, infectious disease, facial pain, and general areas of oral medicine, with more than 750 contributions to literature in the form of papers, abstracts, textbooks, and book chapters. I know we'll all learn a lot from his expertise. Please welcome Dr. Joel Epstein.
Well, hello, everyone. I'm happy to be here from Los Angeles, and I'm going to talk about oral care for caregivers of cancer patients with focus on head and neck. I'm at City of Hope Comprehensive Cancer Center and lead the oral care services, and also at Cedars-Sinai Hospital, where I do the same. And hopefully this will be directed to what your interests are, and obviously directed to the needs of cancer patients that are now survivors post-treatment. I have a long list here of the kinds of complications that patients may experience. I'm going to go through them and highlight just a little bit about treatment. But one of the things that we had done years ago was a study looking at patients following cancer treatment and what their concerns were and what the concerns of the cancer center staff were and what the concerns of the care providers were. And sometimes these don't align. And patients may have interests or needs that they feel are more important, and those need to be presented to the people that can help them with those needs. But what I want to do first is just talk about the oral care of cancer survivors, and specifically in head and neck cancer. These oral concerns are major drivers of quality of life, ability to function and do things that the mouth is designed to do or needs to do. So the first is that we cause damage to the linings of the mouth, that's the oral mucosa, and the long-term implications can result in scarring of the tissues, so limited movement, limited opening, limited tongue movement, for example, thinning of the surface, so that can result in surface sensitivity and increased risk for surface infection. Much of that, one of the main concerns of people following treatment is saliva gland function and saliva itself. So saliva is thought of as how much do you have and is your mouth dry, but it's really much more than that. And one of the qualities of saliva is the thickness. So in some cases, reduced saliva drives many of these complications, but also symptoms and quality of life, such as the ability to speak clearly, the ability to wear dentures, the ability to swallow easily. So it's quality as well as quantity, and that's rarely considered. So patients need to address this, and we'll talk a little bit about treatment just in general sense today. So salivary gland function drives many of the long-term complications, including mucosal damage, and including the rest of the list that I have here, such as sensory change. And sensory change in the mouth can relate to pain, which is obvious, but people don't think of taste and smell very regularly or often. And taste and smell complications are major drivers of nutrition and oral intake and diet requirements, so that providers of supporting the needs of cancer survivors may need to modify things like the food, how often it's presented, and what is chosen. Saliva itself drives tooth damage, and tooth damage drives oral-facial pain, like fractured teeth, cavities, toothaches, and in people who have had head and neck radiation therapy, dental problems may require some surgical interventions that then risk bone damage that may not repair. So prevention of tooth damage is key. And we'll talk about that. And that's a long-term, lifelong concern in our head and neck cancer patients. Because one of the biggest complications, which is shown here, there's my pointer, is soft tissue damage or necrosis. So it breaks down and bone can become exposed. And one of the greatest complications and actually most difficult to manage is bone necrosis of the jaw, where the bone can become exposed, infected, and lead to more bone damage and ultimately to even jaw fracture. Management is complex and challenging for us in the cancer field. But the implication is prevention is key, and that gets back to caregiving and caretaking. Jaw function, such as TMJ pain of the jaw and jaw joint, is common. And why is that? In the head and neck cancer patients, we're doing surgical things, we're doing radiation that may restrict jaw opening, and then that can lead to these problems post-surgically with the jaw, either the upper jaw, the maxilla, or the lower jaw, the mandible, where movement and dysfunction becomes more severe. And so jaw dysfunction can occur as a significant consequence. And this can be driven by scarring within muscles or soft tissue, which then limits movement. So this fibrosis or scarring can lead to difficulty swallowing, difficulty opening, difficulty with tongue movement, and including function of speech and ability to maintain oral intake easily. So all of these things sort of conspire to affect function of the jaw and the oral cavity, which is, of course, the main source or site where food may enter, but we do a lot of things with our mouth. So we eat, we swallow, we speak, and these functions affect nutrition and weight, which then has a potential broad complication for energy and patient function and comfort. One thing that's often not appreciated is the effect of our treatments on appearance and body image. And that's not including teeth, but it's not often thought that way. But even the dental damage, losing front teeth in a setting that affects aesthetics can affect body image, but the soft tissue and the mandibular alterations that the surgery, the radiation may cause are very potentially highly impactful, affecting psychosocial outcomes and even withdrawing from family or meal times because eating is difficult, eating is uncomfortable, and they may not be eating in the same way that they used to. So these are major effects on psychosocial outcomes and functional outcomes. And many of these are driven by the saliva change that happens on the long-term basis. So what is the cause of this? Well, the cause is that wherever the cancer is affecting, the tumor itself may cause damage and fibrosis and scarring and bone loss and discontinuous jaws and other complications in the head and neck. The cancer treatment, though, is one of the main drivers. So the treatment includes surgery, includes radiation therapy. For head and neck, surgery is the primary modality, often supplement with radiation therapy. And with more advanced cancers, radiation sensitizers to make the cancer more responsive is the chemotherapy provided. But we're now using newer therapies that many of you might know of or have heard of, if not in the people you see, of immunotherapy and targeted chemotherapy. These agents are changing the outcomes. They're improving them. Longevity is maintained longer, but they also have potential complications that if the mouth is sore, if dry mouth is present, or if taste change occurs, which I'll outline a little further, then these can be managed in many cases. And the patient needs to tell the caregiver and needs to interact with the cancer and dental team to have the best management possible. So again, why are people immunosuppressed? Well, the cancer itself may be associated with this. The treatments may cause bone marrow or blood count suppression, And then we use drugs like the immunotherapies that may affect immune tolerance. And this abbreviation here is graft versus host disease is a common problem in bone marrow transplants, which, by the way, have an increased risk of head and neck cancers. So it's included in my list for you. But most of the things that we don't think about currently is we think of cancer cure or intent to cure. We used to think of intent to cure or palliation, but now we're thinking a little differently, including maintenance of cancer with suppressing or reducing progression risk. So we are now looking at more chronic maintenance therapies that will extend survival, extend and improve quality of life, but even in the cancers that we can't cure at the initial treatment intervention. So things are really changing. That also means not only are they for the positive, but it also means we will have greater need for care of some of these oral complications. Some of the medications we use also drive numbers of complications. So give you, as an example, opioid pain meds, the narcotics, can cause dry mouth. So that may increase the oral dryness, that then increases all of the mucosal cancer and dental risks and comfort risks that I discussed before. And another group of agents that are used in specific cancers are agents that modify the bone and bone health that can lead to, again, more of this bone damage and necrosis that is a long, chronic, and persisting complication that needs management. This is all complicated by people that may have other comorbidities. So, for example, we really want people to stop smoking if they were. And in some cases, that just doesn't happen. So the core morbid activities that people participate in may be issues, but also things like diabetes may be present. Medications for high blood pressure can also cause mouth problems and reduce saliva. So we need to identify the causes where we can treat them, but also treat the symptom and manage that. And that obviously needs to be reported by the survivor and by the caregiver. And there's many things that the care providers can promote at the cancer centers where these treatments may be required for management. So we want to maintain oral health because of the risks associated with that. And that involves saliva and the oral microbiome, which is now becoming a very important topic. Everybody now is aware of the gut bacteria, the GI microbiome, but very little attention has been paid to the oral to date, and that's becoming really of importance and will become much better understood and better managed, next short term. So just to show you how frequent these things are, this is a summary of a study in patients with advanced cancer, all kinds actually, not just head and neck. And in all types of cancers, saliva gland hypofunction, meaning dry mouth, was present about 80%. That's essentially everybody in advanced cancer settings, probably driven in that setting by medicines like the narcotics and opioids, like some of the other medicines for nerve pain, but also due to the cancer therapies before, and clearly in the head and neck, it's local, regional, meaning it's the radiation and whatever else we've had to do. Because of dry mouth, surface infections are really common, and the commonest one is yeast, and that's oral candidiasis, and that can affect taste. Someone who has a secondary infection may have mouth sensitivity, so they may be able to report that their mouths are sore, they have cracking at the corners of the mouth, taste is changed, and swallowing may be affected. And recognizing those symptoms can lead to a diagnosis, and we can treat it more effectively if we get to the base of what's causing the problem. Dental cavities are increased, probably driven mostly by dry mouth and maybe by oral hygiene. And you can see in this study of advanced cancer patients, it's 20 to 50%. Gum inflammation is a lot of people, and maybe everybody in some studies, and other oral infections are kind of uncommon. Canker sores or apis stomatitis is a unique kind of mouth sore that's more common in targeted chemotherapy. So we're seeing more of these. And of course, we can treat them if we identify diagnose and then provide local management. There can be non-specific ulcers, and the data on how common is dental breakdown, gum disease, and increased cavities is kind of limited because of the way the insurance industry is structured. But we certainly see an acceleration of not only amount of dental disease, meaning cavities and gum disease, but we might see much more rampant tooth destruction. And so early treatment and prevention, which is so important for survivors, is the role of the survivor to identify, but often the caregiver to assist. So I'm not going to talk about the details of treatment, but just to say that saliva complications can happen during therapy. They can be before, actually. Some people may come in with dry mouths due to other causes. And then it can be chronic, and that's one of the drivers of the oral condition after treatment. So again, it's quantity and quality. So what does that impact have? It affects taste, lubrication. So if you're wearing dentures, they're harder to wear. Speech, eating, swallowing, tissue trauma, and again, denture function. It affects oral health locally. But then when we talk about dental gum infection, we also are talking about generalized risk of a local infection causing broader effect, and the oral microbiome shifting that can cause other systemic problems. So what's the treatment? And just in general terms, and this is the role of the patient and the caregiver, is increase fluids. And typically water is the better choice. Some people will choose some of the nutrient drinks and some of the electrolyte-based drinks, but it needs to be hydrating, and volume is needed, because without the base of fluids and people being dehydrated, they're even drier. There are a number of medicines that can treat saliva stimulation if there's residual saliva gland function left, but there's also some other means to wet the surface with different products to deal with the microbiome changes, to deal with the damage that then occurs to the teeth. So like at the bottom line here, there's lubrication, wetting, there's infection risk, but there's the mineralization of teeth. So the calcium and the phosphates that build the hard structures of the teeth come from the saliva. They don't get through the blood, and they don't stay there on a dietary intake. We need to try to stimulate normal function so there's a constant bathing of minerals on the teeth that reduces the risk, but also we can provide specific calcium supplement products that can be applied in the oral cavity if we can stimulate normal function of saliva. So saliva is a real driver of many of these things. I mentioned yeast infections, and providers can see this sometimes, especially if they're doing any oral care. Cracking at the corners of the mouth, shown on this slide, white patches on the corner, and generalized redness or whiteness can be signs of surface infection due to yeast. And then what do we need to do? The first thing we need to do is treat the cause of the condition if we can, meaning saliva. So if we can stimulate saliva function medically through the oncology team, then that will reduce the risk and may actually eliminate the yeast entirely. Tobacco is important in that setting because those who smoke have a higher carriage rate of yeast or candida in the oral cavity just because of smoking. And then we have specific antifungal and anti-yeast medications. But again, if we don't treat the risk, meaning if we can't get more saliva or we ignore that saliva production is a factor, then this will keep recurring. And in some cases, where we cannot stimulate saliva enough, we need to maintain a suppression of the yeast, meaning we don't go sort of for cure or elimination, we go for control, which might mean less frequent use of the anti-yeast or antifungal medication when it's needed. So recognition of dryness in this setting and recognition of candida can allow us to manage things better. And what this will all do is affect taste and oral function and oral comfort that then allows more normal function. So I mentioned a little bit about tooth damage, and why I'm showing you these slides at the bottom is on the left-hand side are obviously an individual with really good oral hygiene, a younger person. And everything looks clean, except if you look right at the gum line, you see sort of a chalky white line. That's what happens when calcium is first lost. So what that has the potential for us to do is to reharden or remineralize that tooth without fillings and to suppress the risk of broad tooth damage, which is shown on the other slide. And actually, you can see some of the same thing where the enamel is more white just above the gum margin here. That's where more calcium is lost. And so this is soft. And if we don't reharden that, it'll break down like the more yellow, darker areas near the gum line are here, which gives us cavities circling the whole tooth. And this can happen rapidly. And then these teeth can break at the gum line, which creates another series of problems. So it's the old story of prevention. If we can find and treat dry mouth, and in that context, we see demineralization, use mineralizing products on the teeth, then we can prevent all this dental damage over here that then can progress to this jaw necrosis that I'm mentioning. So what do we have to do? This comes down to care and caregiving. It's diet. So we try and avoid high sucrose foods, and we try and have people brush before they eat because it's removing the bacteria that will utilize all that sugar or the food products to then metabolize and create dental problems. Oral hygiene matters. That again is care and caregiving. Fluoride and how we apply it may be necessary and appropriate. I mentioned the mineralization, but in the case of, and I haven't mentioned this directly, but in the case of looking at high-risk cavity patients, bacteria shift. They shift to cavity-producing bacteria. So this is a microbiome change, and we can treat that, but we have to recognize it, and we have to use the products that specifically reduce those bacteria. And then again, right to the beginning, if we can affect saliva function and improve it, then we'll reduce all of this risk. And other aspects of the oral cavity now. So periodontal health is affected. Dry mouth leads to more swollen gums, redder gums, more gingivitis, and can lead to periodontal bone loss, which is the actual gum disease of adults or periodontitis. So you lose attachment of bone to the teeth and you have less bone support. All of this leads to inflammatory upregulation, which are called cytokines. All of this may have generalized effects, not just oral. And that's because of this inflammatory upgrade. And I think it's pretty much better understood now that generalized causes of inflammation are things we try to reduce for better health. So periodontal attachment losses increase with dry mouth and where the radiation went. The dental people need to know about this. Periodontal disease and its management in high-dose radiation fields is required. And if we don't treat the periodontal disease, then we have risk of this bone necrosis that I mentioned earlier, and I think I talked just briefly in a minute. The longer term effects on the soft tissue lining in the mouth include something called chronic or recall mucositis. So during treatment, people get a bunch of mouth sores. It's expected. We are getting better at suppressing that as well. But this can persist. We used to think it pretty much always went away, but it also can be triggered with something called recall mucositis with, say, another infection or stress occurs, increasing inflammation. We're also doing things in the cancer therapy world that I was mentioning, like maintenance chemotherapy, abbreviated CT, and using targeted agents and immune inhibiting agents that is increasing the frequency of either recurrence or new problems with the lining of the mouth. And that's this T cell mediated stuff. So these pictures show generalized redness on the left and generalized thinning of the tongue, patchiness around the lips in this case, and on the top of the tongue with ulceration. This can be the same degree of sensitivity as the mouth problems during and early after therapy, but these are chronic now, so we're seeing more of that. And this is the description of how we can prevent with better oral care, reducing inflammation, but we have a raft of local therapies for local mouth complications, as well as general medical therapies if needed for when it's broader areas are involved. These aren't important to know. It's just to know that if this is reported to the people at the cancer team, this can be addressed and hopefully managed effectively. Um, this is a couple samples or a couple photos of early bone necrosis. So in the bottom left, this is the tongue side of the tooth. That's actually a very common site for this to happen. And that white area is bone that's exposed. You can observe this if you're doing oral hygiene. And if it's minimally exposed in an area like there, or on the other slide, right behind the molar tooth near the back, a small area that usually is like the tip of the iceberg of what's going on underneath. So this bone necrosis, which is facilitated or accelerated by radiation effects on bone, but also by some medicines, and also by pre-existing dental disease. So if you have lots of inflammation in the bone, that can lead to bone breakdown. This is more common in the lower jaw than the upper jaw, but it can occur in both. We're focusing on head and neck, so that's really a radiation-induced tissue, long-term, lifelong problem, actually. So the risk then is this can occur with local trauma spontaneously, and sometimes with a dental intervention. So if there's a dental problem and we have to do some things to the gum or surgically, this may break down, and then it becomes radiation necrosis. We have to do some detailed imaging. There are numbers of treatment approaches that are aimed at reducing the risk of needing surgery. But in head and neck radiation therapy, people, if we need to do surgery to find viable bone that will allow this to heal, then we know where the radiation fields went, and we can plan that. Obviously, everybody would prefer to avoid surgery, so we always start with the medical management to improve the potential for this to heal. But sometimes it goes right on to the rest of treatment. So, meaning surgery and reconstruction. Radiation therapy in particular, but also complicated by surgery, can cause lymphedema or fluid accumulation in tissues. Yeah, and it's a soft tissue swelling initially, usually within about the first year of treatment. If it's present, this may mature with scarring, so it becomes dense, firm scar tissue, and that can affect function and appearance. So some of the basic therapies are, again, massage. You can be instructed to do this at home. There's red and infrared light treatments that'll probably help with that, but there's a number of interventions. This is best treated by prevention rather than trying to recover function, because once the scar tissues form, it's really hard to manipulate around it. So on the lower left is a person who's had radiation therapy. You can see there's no hair growth. That means on the inside that if this was head and neck radiation, he's most likely to have effect on the bone cells and the blood supply to the jaw that then prevents healing if some inflammation or trauma occurs. This is actually him trying to open his mouth. And so this manifestation is the scarring that limits jaw opening, and sometimes to the point that oral hygiene can't be conducted. Then we have to rely on mouth rinses and other devices to try and help clear the bacteria from the teeth, and again, reduce dental disease that then leads to bone necrosis. This can be pretty debilitating stuff and hard to manage. So prevention is the key. When swelling is noted before the restriction and scarring has occurred, this needs to be addressed as quickly as possible. This effect, in addition to saliva, which I mentioned before, can affect swallowing, which then affects everything from swallowing medications, especially pill form, and some people can't, that can, and limited jaw opening, as we showed before. So swallow is affected by restriction in movement of the tongue, the cheeks, the lips, the jaw. Swallowing is affected by how well you can masticate the food, and saliva and the mucosal function and sensitivity. So it's all these functions coming together. And this can extend into the throat and the esophagus when it's head and neck radiation therapy. So the causes are what we said before: the tumor, the surgery, the radiation, the treatments that we need to do. And really, interventions early are key. But if fibrosis is beginning, we can still intervene, and we do a better job at prevention than management. Other things to mention that a caregiver certainly can hear from the survivor is oral facial pain. So pain can occur to any cause that may cause pain. And so, for example, if it's a tooth problem, one, we hoped we would prevent those, but when we haven't, we treat them. So we treat the cause whenever possible. Pain may also increase anxiety and depression, so we need to be very aware of that. Treat the cause when possible. If it's nerve pain damage from the treatment, we use nerve pain medicines. It often requires multidisciplinary care, meaning a team, which I'm going to get to in just a bit. So for some things, we can use medications that work on the surface. If the mucosa is sore, we can use oral pain relievers, and in a graduated manner that the WHO has developed a scale that's useful. But what we often don't get, and this needs to be presented if the pain is still ongoing, or say the pain is different quality, like it's electric or stabbing or tingling, then we need to use medicines for nerve pain, not just the pain relievers like Advil and opioids or narcotics. So we need to be aware of that, and so does your care team. If there's a TMJ problem, we treat it the way we would other TMJ, recognizing the cancer status, muscle relaxants, physiotherapy, and then some integrative treatments. So we can manage most of these things and improve the quality of life, but it requires often a team. So, I did need to mention a little bit about taste. It's one of my focused concerns that patients have, and it's often ignored or because the research, which is really actively increasing now in the last 5 years, is looking at how do we intervene and how can we make it better. So with everything else, as mentioned, it affects the health of the soft tissues. Saliva function matters, so we treat saliva when we can, or when it's needed and when we can. We deal with the oral status, so oral hygiene. These are all things that a caregiver can emphasize. Then we start to get more into medical and then into diet and nutrition. So you might need working with the diet and dietary people, but there's management for taste. I listed it briefly. There's more than this now that may help many patients. And the last thing I want to mention about survivors in head and neck is they're the group that's at highest risk for new cancers. They've had one already. And the risk is like 9 times what it was before. So what that means is any mass, any site of pain that's new, that should be any area that's bleeding, that should be looked at and evaluated because that risk is there. And with early detection, we can do simpler and less invasive treatments. We may also be able to start to suppress cancer risk with preventive approaches that is more complex, that in some cancer centers that will be available. Dental care then, so getting sort of to the summary. What cancer survivors often need is more frequent dental visits, and because they may be at increased dental risk due to the saliva changes and the other things we've mentioned. They may have more symptoms. Some are treatment related, some are dental, and so that needs to be addressed by someone hopefully with some experience, which I'll mention in a minute. The person seeing the patient needs to know what their cancer was, stage and prognosis. They have to understand what the therapy was, meaning radiation, where it went, and the dose. But they also have to know, what about maintenance therapies, as I mentioned earlier? Is the person on something that may affect, say, wound healing if you do a dental procedure that's necessary? We can do non-surgical care really without risk. That'll maintain the health and reduce the risk for needing surgery. But if we do surgery, and if it's a head and neck radiation patient, we try to avoid areas that are at highest risk unless there's no other option. We try and do non-surgical things to manage, say, a dental infection when possible. And if it's a high risk, then there are some interventions that may promote wound healing that we should be beginning before the treatment is provided by the dentist. So the dentist needs to communicate with the cancer team or be part of it and refer appropriately. So to finish up, cancer is now, we look for cure always. For in the cases where we can't, we may be looking at how do we make this disease chronic? What's the maintenance of this condition so it doesn't get bigger and become a bigger problem? One of the things that I didn't mention at the beginning, but it's a pet peeve of mine, is the mouth really is part of the body. Dental insurance and dentists and physicians have been separated for a long time. And in the cancer world, this all comes together. It can't be separated. not only from the etiology, but the management perspective. So a team matters. A lot of times there's underreporting of the complications. So if you have a sore tooth or a loose tooth and you're seeing your oncologist, they may say, you may not think it matters as a provider or as a patient or as a caregiver, but they really need to be informed. So if you underreport, they can't say, oh, well, then you should see the dentist or you need to see a specialist, and we have a consultant, or nothing can happen because it's not presented. So always let your providers know what's happening, in this case, in the mouth. Dental role is from the beginning to the end, prevention to treatment and survivorship. And the best team for this is the integrated cancer team. That's part of what the Head and Neck Cancer Alliance sort of emphasizes, is it's really a team coordinated management that will give the best possible. And that includes the survivor and the caregivers that support them so importantly. So I would like to end with thanking the caregivers for the work that they do, and for you who are here and for your interest. And be happy to take questions when the question and answer session begins. Thank you.
Thank you for joining us today for this important topic. If you have any questions, feel free to reach out to us via email at connect@headandneck.org or visit our website for more details, www.headandneck.org. We hope that you'll join us next week for our online discussion, where you will have a chance to chat with other caregivers and professionals about these important topics. It's an honor to connect with you. Wishing you strength and peace in the week ahead.